Welcome back. For our next section, I'm pleased to introduce Dr. Samuel Goldhaber, who is professor of medicine at Harvard Medical School and the clinical chief of our cardiovascular division at Brigham and Women's Hospital, also our recently former chief of vascular medicine, who is really going to speak to us about the current state of the art in management of venous thromboembolism. So thanks very much, Sam.
Thank you, Akshay. What I'm going to do is talk about pulmonary embolism mortality in the United States, COVID-19, the pathophysiology and diagnosis of venous thromboembolism, the optimal duration of anticoagulation. I'll sing a requiem for provoked versus unprovoked VTE, terms that are no longer recommended. Discuss DOACs for cancer patients with VTE, and if we have time, discuss advanced therapy for pulmonary embolism beyond anticoagulation. Now, I have some bad news for everybody. The median age of death from pulmonary embolism in the United States was 73 in year 2000, and now the median age of death has dropped to 68 in year 2017. And this problem with pulmonary embolism mortality is a part of a much larger problem, an increase in all-cause mortality in the United States, to be contrasted with a continuing decrease in mortality in cancer in Canada and in Europe. Here you see that we were doing very well with our age-adjusted mortality, but since year 2015, we've had an increase, and this is very troublesome. We think that socioeconomic factors are important. The decline in life expectancy is greater among individuals with limited education and income, and the gradient in life expectancy based on income has widened over time. Focusing on pulmonary embolism over this period from year 2000, we see in women between ages 25 and 65, the PE mortality was coming down, but then starting around year 2006, it's been going straight up in women. The same pattern is seen in men, except the slope for increase in PE mortality is steeper in men than in women. For those age 65 and older, there's nothing quite as drastic. Women had been enjoying a decrease in pulmonary embolism mortality, and now there's just a tiny slope upward for those age 65 and older. For men, they too had been enjoying a sharp decrease in PE mortality, but even the older men, 65 and older, have had an increase in pulmonary embolism mortality for about the past 10 years. Now, on top of all this, we have COVID-19 to deal with, but I'd like to start 100 years ago with the Spanish flu to see if there are any similarities or lessons to be learned there. They did know 100 years ago that wearing masks was very important. And in Brookline, Massachusetts, which abuts Brigham and Women's Hospital, which is just over the border in Boston, there was a large field hospital because the brick and mortar hospitals were overflowing, and these were staffed by many volunteers as well as professionals. They did not have smartphones 100 years ago, but they did recognize that people who are in quarantine are not isolated if they have a Bell telephone, and that Bell service brings cheer and encouragement to the sick and is of value in countless other ways. Also, in terms of staying at home, they advertised heavily for this 100 years ago and said it has never been easier to save lives. So they were socially distancing also. And now we fast forward 100 years to COVID-19. And with respect to venous thromboembolism, there are some peculiarities about VTE and COVID patients. Pulmonary embolism is much more common than DVT in COVID-19 patients. Ordinarily, about 2/3 of VTE is a DVT and 1/3 is a pulmonary embolism. But here, almost all are PE with few DVT. The rate of pulmonary embolism in COVID ICUs can exceed 20% of the patients. We think a lot of the PEs are really in situ thrombosis with microthrombi in the lung arteries. Another curiosity, when we administer standard low molecular weight heparin to COVID patients in the ICU, there is a lot of breakthrough VTE that occurs despite standard VTE prophylaxis. But there's also dramatic macrothrombus. This is an autopsy patient who died of COVID at our hospital. And this large thrombus was found in his right ventricle. Here you can see where there was a venous valve. So we have definite evidence that this clot came from the deep leg veins and embolized to the lungs. It was so big it couldn't get through to the pulmonary arteries and rested in the right ventricle at the time that he expired. But here is an example. In his autopsy, he also had tiny thrombus in pulmonary venules, as seen here. COVID also causes a particular type of coagulopathy with decreased platelets, increased D-dimer, fibrinogen, prothrombin time, and fibrin degradation products, and increased factor VIII levels. So how do we put all of these hemostatic abnormalities and adverse clinical outcomes into perspective? Well, many of the COVID-19 patients who develop VTE have underlying risk factors, age being a very important one, and no doubt being bedridden is also very important, and also having underlying pulmonary disease, COPD, or heart failure are important. And when these patients develop their viral pneumonia, there is an inflammatory response, and the endothelial function becomes disrupted, and they become super infected. You get tissue factor inhibition, lymphopenia, and inflammatory cytokines increase, such as IL-6 and C-reactive protein. The result is these hemostatic abnormalities cause pulmonary microthrombi, intravascular coagulopathy, often myocardial injury with an increase in cardiac biomarkers. And for clinical outcomes, we see venous thromboembolism, both micro and macro, myocardial infarction, and occasionally disseminated intravascular coagulation. This is an autopsy specimen not from our hospital. This patient died of ARDS in an ICU. The lungs were 2 to 3 times heavier than normal. The heart, this is actually the right ventricle that's hypertrophied. And here you see the lungs. And if you look at the white arrows, you will see a lot of these small thrombi throughout both lungs. This is typical of the COVID VTE. In the case series from France, there were 107 COVID ICU patients, and 22 developed VTE. 20 of the 22 had received VTE prophylaxis. Median age, 57 years. 59% were men. The median BMI was 30, and almost all the patients in this ICU had ARDS and were intubated and ventilated. Here we see in this study that 62 of these patients developed some type of thrombotic complication, 25 PEs, 3 DVTs. A lot of these patients were getting continuous dialysis at the bedside. 28 patients had clotting of their CVVH circuits, which impeded their dialysis. 2 patients who were on ECMO had thrombotic occlusion of the pump, and there were arterial problems as well. 2 strokes, 1 patient with peripheral arterial occlusion in the leg, and 1 patient with mesenteric arterial ischemia. Well, what we did at Brigham and Women's Hospital when we saw these reports in ourselves, had patients who had breakthrough pulmonary embolism with standard low molecular weight heparin prophylaxis, is we changed our own guidebook and doubled the prophylaxis to enoxaparin, going from 40 milligrams once a day to 40 milligrams twice a day. Now for the pathophysiology. I think most of us are familiar that pulmonary embolism causes anatomical obstruction, hypoxemic vasoconstriction, and adverse neurohumoral effects, which increase the PA pressure and increase right ventricular afterload. This increase in afterload will increase right ventricular wall tension, lead ultimately to a decrease in coronary artery perfusion, and also cause right ventricular dilatation and dysfunction, which can also cause a decrease in right ventricular cardiac output, and ultimately a low output state with a decrease in systemic perfusion. What is less well known is that when we do a routine stain, a trichrome stain, for example, on a patient who's had pulmonary embolism, it looks red. We're thinking to ourselves that this is just a bunch of congealed red blood cells. But if we go the extra mile with special stains, we'll see this brownish stain is lighting up all the polymorphonucleoleucocytes because this tissue is inflamed, and the polys are migrating into this inflamed tissue. And this blue stain is activated platelets, which contain a lot of thrombogenic inflammatory mediators. And these activated platelets are just ready to burst and do their damage. Now, the activated platelets also secrete these mitochondria seen in green. You can see it just looking at the mitochondria, and it's kind of mean and ugly looking. And these will, in turn, these activated platelets promote inflammation. And what we get with pulmonary embolism and DVT is a combination of fibrin strands, which are going to require anticoagulation, but we'll also see a lot of these activated platelets. So in terms of VTE and atherosclerosis, there are a lot of common factors. The risk factors are shared between VTE, MI, and stroke, including obesity, hypertension, cigarette smoking, high cholesterol, diabetes, unhealthy diet, emotional stress, and estrogen therapy. These risk factors come together to promote inflammation. Inflammation promotes hypercoagulability and endothelial injury. And at that point, there's a fork in the road. The patients can develop venous thrombosis, or they can develop atherothrombosis with MI and stroke. If they have an MI or stroke during their lifetime, they're twice as likely as normal to develop a PE or DVT. And if they go down the route of PE and DVT, they have double the likelihood of developing MI or stroke. So we, from a vascular medicine perspective, look at pulmonary embolism as one of a series of overlapping vascular diseases that include MI, stroke, heart failure, and even atrial fibrillation. Inflammation appears to be the common underlying process. And in this large Danish study of almost 17,000 PE patients with more than 65,000 controls, we see that those patients who suffer pulmonary embolism 1 year out have a 2 to 3 times higher than expected rate of MI or stroke. And even following them 20 years out, they have about a 30% each year annual risk higher than average of MI or stroke. Now, in terms of VTE diagnosis, I believe the algorithms have been very well worked out. We know we should assess the clinical probability, and Wells criteria are used most often. We know that in most instances, we should get a D-dimer level. And if the D-dimer is less than 500, we can exclude pulmonary embolism as long as the clinical probability is low to moderate. And if it's greater than 500, we'll get a CT scan. But I think the big change over the last couple of years is the introduction of the age-adjusted D-dimer for patients greater than 50 years of age. And when we adjust for age, what we do is we multiply the patient's age by 10. So if the patient's 70 years old, the upper limit of the D-dimer becomes 700 nanograms per milliliter. This was found to be very accurate in the ADJUST PE trial. And when we do this, we find 5 times as many negative D-dimer tests in patients who are older than age 75. And therefore, we can cut down on the number of CT scans in a safe manner compared to what we do now. In terms of the electrocardiogram, this is one of my favorites because you see the sinus tachycardia as expected, and the classical S1, Q3, T3 as expected, but S1, Q3, T3 is quite uncommon. The most common finding is T-wave inversion and leads V1 through V4, another sign of right ventricular strain. But rarely do you see both of these signs, T-wave inversion, V1 through V4, and S1Q3T3 in the same ECG. For DVT, ultrasound in the transverse view is the way to go. This is the right common femoral vein without compression. In a normal vein, the lips of the vein would be able, with handheld compression, to touch each other. They don't, and this is diagnostic of acute DVT. If you have the lights down, you'll also see a mass here, which is acute femoral vein thrombosis. Now, the guidelines for how we think about VTE have changed radically within the past year, and these were published in the European Society of Cardiology PE guidelines. These guidelines state that terminology such as provoked or unprovoked PE or VTE is no longer supported because it's potentially misleading and not helpful for decision-making regarding the duration of anticoagulation. Here you see in the Framingham Heart Study, Framingham, Massachusetts, patients followed for 15 years, the rate of recurrent VTE was the same, almost superimposable in patients with unprovoked and provoked VTE. Cancer patients had much more recurrence as expected. And in this Danish study of more than 73,000 patients, for the first 6 months after diagnosis, the rates of unprovoked VTE shown in black and provoked VTE shown in red are virtually superimposable. The cancer patient shown in green, as expected, will have more recurrence. The most important study proving that we should pretty much abandon the terms provoked and unprovoked is the Einstein Choice trial, where 60% of the patients enrolled in this trial of more than 3,300 patients had provoked VTE. And to get into the trial, the patient had to have been treated with anticoagulation for 6 to 12 months. Then the patient could be randomized. It was double-blind study, either to rivaroxaban 20 milligrams a day, rivaroxaban 10 milligrams a day, or low-dose aspirin. And the patients were followed for a year to see how many developed recurrent VTE and for bleeding complications. And you see here, with respect to recurrent VTE, low-dose aspirin is the big loser. And there's no difference, there's no dose-response curve. Rivaroxaban 10 milligrams daily is as effective in preventing recurrent VTE as rivaroxaban 20 milligrams daily. And that's why the FDA has subsequently approved lowering the dose of rivaroxaban for extended duration treatment to 10 milligrams a day after the first 6 months of treatment. Taking a deeper dive in Einstein Choice into the provoked risk factors, those provoked risk factors which had the most influence on causing a recurrent VTE were heart failure, obesity, chronic kidney disease, a family history of VTE, hereditary thrombophilia, and immobility. Now, the European Society of Cardiology says that what we should do, the way we should think of the risk of recurrence, is either low, intermediate, or high. Low, less than 3% per year after stopping anticoagulation. Intermediate, 3 to 8% per year recurrence after stopping anticoagulation. And high, risk of recurrence, greater than 8% per year. The high-risk patients are those with active cancer or the antiphospholipid syndrome. The low-risk patients are those counterintuitively who've suffered major trauma or who have undergone major surgery. But pretty much all the other patients are in this intermediate bucket with minor surgery, hospitalization for medical illness such as pneumonia or heart failure or COPD, pregnancy or estrogens, long-haul air flights, inflammatory bowel disease, autoimmune disease, or no identifiable risk factor, which we used to call, until these guidelines came out, unprovoked VTE. It's part of this larger group of risk factors for an intermediate risk of recurrence. So the ESC states that extended oral anticoagulation of indefinite duration should be considered for patients with the first episode of PE and no identifiable risk factor, or a persistent risk factor, or a minor transient or reversible risk factor. And these three sets of risk factors really are almost everyone in the universe with DVT or PE, except for those patients who have had major surgery or major trauma. So we thought, our thrombosis research group, in an editorial we had published before the guidelines came out, that we should put unprovoked and provoked VTE in the same bucket. And the risk of recurrence should be the driving force to determine the duration of anticoagulation. Now, can DOACs replace low molecular weight heparin monotherapy in cancer patients with VTE? It's very challenging to treat cancer patients with VTE. Cancer itself is thrombogenic. There are many reports that you get high rates of recurrent thrombosis, even if the patient's being treated with warfarin and the INR is in the therapeutic range of 2.0 to 3.0. Patients with active cancer are getting chemotherapy, and the cancer chemotherapy is both thrombogenic and thrombocytopenic. We have to worry about occult metastases as major sources of bleeding. And we have to be concerned about interactions among anticoagulants and novel chemotherapeutic agents that are tailor-made, custom-made for the patient in the laboratory. This is totally uncharted territory. And of course, many of the cancer patients are frail. In the CLOT trial, published in 2003, patients who received low molecular weight heparin monotherapy with dalteparin had a 50% reduction in recurrent VTE compared to patients who were receiving oral anticoagulation with warfarin, which was the only oral anticoagulant at that time. But fast forwarding, the updated guidelines for the National Comprehensive Cancer Network endorse all 4 of the DOACs as alternatives to low molecular weight heparin monotherapy for cancer patients with VTE. And here we see a very brief summary. Edoxaban and rivaroxaban compared with dalteparin, the low molecular weight heparin that was paired against the DOACs. Edoxaban and rivaroxaban both had better efficacy than dalteparin, but less GI safety and more GI bleeding. The most recently published trial, the Caravaggio trial with apixaban, apixaban had the same efficacy as dalteparin and the same safety. So at the moment, apixaban seems to be the leading DOAC, but there are more important studies that are in the works. And I think we'll have additional results within the next year or so. All right, let's talk about those patients who are so ill from pulmonary embolism that anticoagulation by itself is not adequate to do the job. And we can add advanced therapies such as thrombolysis with TPA, or surgical or catheter embolectomy. There are so many choices for these ill PE patients that most hospitals have developed a pulmonary embolism response team, or a PERT, with representatives from all of the relevant disciplines. And this is important because the vascular medicine folks can huddle with the cath lab and the cardiac surgeons and radiology and come up with a plan and present one plan to the patient, to the family, and to the primary team. And I think the PERTs have come a long way in helping us improve our communication. Over the past 30 years for pulmonary embolism thrombolysis, there's been a trend toward lower doses of thrombolytic therapy, which are associated with less major and less minor bleeding. Not only lower doses, but also lower, shorter durations of infusion, which will lower the cost of therapy and decrease the hospital length of stay. We have a big menu to choose from. We can give TPA through a peripheral vein, give it systemically in the FDA-approved dose of 100 milligrams as a continuous infusion over 2 hours. A non-FDA-approved regimen, which is used off-label in patients where there's a high bleeding risk, but no catheter option and no surgical option, is 50 milligrams over 2 hours. With catheter-directed thrombolysis, we can use ultrasound-facilitated catheter-directed thrombolysis, an FDA-approved dose of 24 milligrams. So this is 1/4 of the systemic 100 milligram dose. And in recent dose-finding studies, TPA given with ultrasound-facilitated catheter-directed thrombolysis, TPA could be given in doses as low as 8 milligrams over 2 hours. We call this 1/10 dosing compared with the standard 100 milligrams. Let's not forget ECMO, or open surgical pulmonary embolectomy. Here you see an ECMO circuit on the left and an operating room on the right. The current feeling is that the patients who go on ECMO for pulmonary embolism have the best chance of survival if they have a surgical pulmonary embolectomy, if the hospital has that skill set. The benefits of this most advanced therapy are you can, in the majority of cases, rapidly optimize the blood pressure and right ventricular function by permitting a pulmonary embolectomy. You can optimize and maximize the removal of clot. And now in patients who have not required cardiopulmonary resuscitation prior to surgery, the mortality rate has really plummeted to as low in some institutions as 2%. But there are major risks as well. About 1/5 of the patients require prolonged mechanical ventilation. 1/5 require hemodialysis. And in those patients who've undergone CPR prior to going to the operating room, their mortality is a sky-high 25%. So I have 6 take-home points and then a couple of questions. Pulmonary embolism shares the risk factors and the pathophysiology of MI, stroke, and peripheral arterial disease. Pulmonary embolism confers an increased risk of MI and stroke. For extended duration therapy, rivaroxaban is 70% more effective and as safe as aspirin to prevent recurrence. And it doesn't matter whether you give rivaroxaban 10 milligrams a day or 20 milligrams a day for this extended duration treatment after the first 6 months. We should abandon, going forward, the terms provoked and unprovoked because, as we saw, many of the provoked PEs and provoked DVTs had as much likelihood of causing recurrence if anticoagulation was stopped compared with unprovoked VTE. The DOACs are reasonable alternatives to low molecular weight heparin, particularly in cancer patients who do not have gastrointestinal cancers. And we should consider advanced therapy for pulmonary embolism when anticoagulation alone does not suffice. And we have a lot of choices: thrombolysis, administered systemically or through a catheter, ECMO, and open surgical embolectomy. Here are some supplemental references. And coming up were 2 board questions. Question number 1, in the United States, PE mortality rate is increasing, decreasing, staying about the same, increasing in men, decreasing in women, or decreasing in men and increasing in women. Now, there are 463 participants in the course who are online. And I think it's pretty clear here that A is routing, not with 97% of the vote, is routing B, which is 1% of the vote, and D, which has 4% of the vote. So, right, this is affecting men and women and unfortunately increasing regardless of age. So we're going to go on to the next slide, question number 2. In patients more than 50 years of age, calculate an upper limit of normal for an age-adjusted D-dimer by multiplying the age times the D-dimer, the BMI times the D-dimer, the age times 10, the BMI times 10, or the D-dimer level times 10. And now we have 467 who are online eligible to vote. And again, this seems like a route that age times 10 is winning this contest with about 95% of the vote. And the other options are getting between 1% and 4% of the vote. And age times 10 is the correct answer. So at this point, I want to thank you for being attentive and engaged in this lecture. The field is advancing rapidly, and it's good to stay abreast of the changes. Thank you very much.
Well, thanks, Sam. As always, a really spectacular survey of the sublime and the mundane, I think, as it relates to venous thromboembolism. And I think a lot of questions about COVID, as you might expect. But before we get there, a few fundamental questions. One is, any difference in the management, and particularly with regard to duration of anticoagulation of deep venous thrombosis and pulmonary embolism? Should we treat those as the same entity?
Yeah, I think that that's a great question. In some respects, they are really the same entity, but in others, if you have a way of keeping the DVT confined to the leg veins, the mortality rate will be 0. And actually, I'm just going to mention that there's something called the factor V Leiden paradox. For some reason, the DVTs that form in patients with factor V Leiden are much stickier than normal DVTs. And so those patients have many fewer PEs and have a lower mortality rate.
So, Sam, I guess one of the questions, and it follows on really this D-dimer issue, is can we use D-dimer in the wake of what you've told us about the relationship between risk for recurrence and the duration of anticoagulation intensity? Can we use D-dimer at all to help guide our decision making? We used to say maybe at 6 months, if the D-dimer is low, you could stop.
Well, I used to do that, but then I'd be calling up a lot of the patients a year later and apologizing as that they have to come into the hospital with a PE or DVT. It had its day, but then the group from Hamilton, Ontario, really proved that it doesn't work unless you're in some sort of culture where being wrong 10% of the time is acceptable. And I don't think any of us practice that way. So the D-dimer is great as a diagnostic screening test. There's some thought that very high levels might predict a dire prognosis in COVID-19, but it can't be used reliably to help us determine when to discontinue anticoagulation.
Perfect. And the last thing before I get to the COVID questions, and that is just in a nutshell, you talked a lot about the options for management of those patients who are refractory, but when you're thinking about selecting patients for thrombolytics or advanced PE therapies, what's in your mind about that decision making?
Sure.
We didn't have a chance to talk about the right ventricle and other biomarkers.
Yeah. So I think the first thing is what is the blood pressure, the heart rate, and are the patients having warm extremities? Much like you might evaluate a heart failure patient, is the patient hemodynamically stable? And if the answer is yes, it gives you a few more hours to think about what to do than if the answer is no. The problem is that if you have a dysfunctional dilated right ventricle, the more dilated the right ventricle, the more dire the prognosis. And if you have an elevated troponin level, that plus a dilated right ventricle is a bad prognostic situation. And I don't mean just like a little bit of dilation. I mean a lot of dilation. A right ventricle end diastolic diameter compared to a left ventricle should be about 0.8 for the ratio. But if you're in all the research studies that we do, we use 0.9 as a cutoff. But in clinical medicine, you really need to be concerned if it's greater than 1.0, right ventricle to left ventricle. If you see the interventricular septum bowing to the left, and at least that's telling you at the extreme, don't discharge this patient on the DOAC. Keep the patient here. Watch the patient. The patient will often declare whether they're getting better or not. I think one of the if they have persistent hypoxemia, those patients probably need advanced therapy. If they just continue to feel crummy and aren't bouncing back, those patients often benefit from advanced therapy. For the patients who are hemodynamically unstable, I think it's easy to say the patient needs advanced therapy. And then depending where you're practicing, you're going to have a lot of different choices of which way to go. And depending on what time of day it is, whether it's a major holiday or a minor holiday, and what the skill set is of your colleagues, that will also help determine what you choose.
Fantastic. And then in the last 30 seconds, I think I'll just let you comment a little bit on your approach, given what you've told us about COVID, to the selection of patients for anticoagulation. Should everybody get it? Should it be a risk stratification?
Well, there are literally billions of dollars being invested in research to answer those questions. I think from what we know so far is if you're in an ICU, the likelihood of getting VTE is very high, and the likelihood of breakthrough VTE despite standard prophylaxis doses is very high. Then there's a gradient downward. If you're in a step-down unit in the hospital with COVID, you still have to worry about VTE, but less so. And if you're an outpatient, much less. It's much less of a problem. And we really don't know at all whether outpatients should receive VTE prophylaxis. But I think they probably should, because we would give, the FDA's approved rivaroxaban for extended duration prophylaxis after a regular pneumonia. Why wouldn't we do the same for a COVID pneumonia? So I think we would, but we wouldn't have the same worry level for an outpatient with COVID as for a ventilated inpatient.
Sam, thanks so much, as always, for participating and
Rob.
for an excellent sort of survey of a complicated topic. I think we'll close there and move on to the next discussion.